Hello and welcome to Health Matters on Channels Television. We're so glad you could join us. I am Mary Alale Yusuf. Some years after the Second World War, the World Health Organization was formed. The vision of the founders was the highest possible standard of health for all people. The WHO Constitution was the first document in history to formally recognize health as a human right. Now, this body is 75 years old, and according to the Director General, Dr. Tedros Ghebreyesus, has made significant progress towards realizing that vision. Today, more than 7 decades into the journey, the theme is health for all, with sub-theme improving public health. How much has been achieved in the health space and where do we go from here? My guest is a public health physician and director, Global Health and Infectious Diseases Institute, Nasarawa State University, KEFI, Dr. Akiala Ishaku. You're welcome to the show, sir.
Thank you for having me, and good morning, good afternoon, viewers.
So back then, it was recorded that health expectancy was about 48. Life expectancy was about 48 years. And now the World Health Organization says that has gone up to 73. But in Nigeria, I'm aware it's not that high, maybe 52 or thereabouts, but it has improved. What factors would you say contributed to the improvement of life expectancy in Nigeria?
So, the audio is bad. So thank you so much for having me, and I wish to also congratulate all workers globally on the World Health Day that was celebrated, and congratulations to WHO for clocking 75. Looking at our demographics in terms of life expectancy rate, you will discover that it has dropped over time. In 2000, when we celebrated Health for All, the life expectancy was about 62%. In 2023, life expectancy is about 52%, although it differs with sexes. For male is about 52, and for female is about 54. And so there are a lot of factors that contribute to this, and that's why the topic or the theme for the WHO celebrating at 75 was brought to bear, health for all. You know that basically defining health for all is having a multi-sectorial, holistic call that has to bring around industries coming together to provide health care or health to citizens at their doorsteps. And this implies that health for all translates to having access to health infrastructure. Having access to health infrastructure goes beyond the physical infrastructures that we see. It has to do with having access to drugs, having access to vaccines, having access to even health personnel, having access to health awareness. Health for all also translates to having a very clean environment with sanitation, having safe and portable drinking water. Health for all translates to understanding preparedness for disaster and also doing a lot of mitigations towards that. Health for all also translates to about rehabilitation, the mental well-being, and the social status. So health for all talks about the social determinants of health. So that brings to bear the question that you raised about understanding why do we have drop in terms of life expectancy rate is because most of these indices that I've mentioned as a country and as a nation, we are not able to meet up with those standards and those parameters. We are not able to meet up with clean, safe environment. We have a very poor sanitation indices and outcomes. In so many places, we don't even have sanitation law in place.
Okay, Dr. Ishaku, let me just pause you a little bit there. We'll go into what our challenges are very soon, but let's celebrate first. Since the WHO came to a formation, to being, there are several diseases that have been eradicated. Can you take us through those? I'm very happy about one, yours.
Yes, I think in the journey so far, we need to commend all health workers and all hands on deck for actually putting in their best in terms of expertise, in terms of skills in eradicating so many diseases. We saw the advent of yellow fever, we saw the advent of chicken pox, we saw the advent of smallpox, we saw the eradication of even polio that we celebrated as a country, and so many other diseases that were eradicated over time. We saw the advent of novel and innovative vaccines that were being produced to eliminate these diseases. We saw even a crashed in time series of the development of COVID-19 vaccine. Above all, what the COVID-19 pandemic brought to us, we saw how nations, WHO was able, and health workers around the world were able to tackle most of the pandemic. And I think that kudos go to all health workers around the world that have given in their best in terms of containing diseases, in terms of going into healthcare system strengthening, in terms of doing a lot of surveillance, either active or passive surveillance, in terms of even contact tracings for a lot of infectious diseases. Also, kudos go to biotech companies that were able to manufacture most of these vaccines, because, without the vaccines, we will not be talking about disease eradication. Also, kudos go to a lot of policies, health policies that were brought to bear to see that we're able to mitigate and be able to push in that directions when it comes to eradication of vaccine preventable diseases. Even in terms of healthcare system strengthening, how sustainable most of these policies are in terms of sustaining healthcare system. So I think that it is quite key for us to commend health workers and WHO for creating that platform for people to be brought to bear, to be able to bring to most of the advances and the progress we have achieved so far.
There are certain diseases that the World Health Organization focused on for the first 20 years after its inception. Some of those diseases are tuberculosis, malaria, yours, syphilis, smallpox, and leprosy. And a lot of work has been done, a lot has been achieved. Yours has been eradicated, smallpox has been eradicated, syphilis is under control and all that. But for malaria in Nigeria, the progress is now at a standstill officially. That's what the World Health Organization says. Malaria progress at a standstill. What are the hang-ups? What is causing the progress to stall? And what really are the hang-ups and what's causing them? That's really my question.
Yeah, so understanding the indices for malaria control program in Nigeria has not been too that positive in terms of outcomes. You will also agree with me, based on literatures on ground and reports that we'll have, is that it is one of the major causes of mortality for under 5, and also is implicated in mortality for maternal mortality, most especially. Most of the reason why there are a lot of hangouts, it goes beyond just what we see in terms of programmatic perspective. You also need to look at the political will. Mary, what have we done as a nation in terms of political will to bring this to an end? What are the kind of policies do we need to bring to bear, bring on board to be able to control this? We also need to have a paradigm shift in terms of thinking, to look at that controlling malaria is not all about getting the diagnosis, getting the person to actually test for malaria and then you treat for malaria. We need to have a One Health approach to look at the dynamics. what are the environmental factors that we need to look into. We are still battling with, just I told you about One Health, what Health for All implies is of about having a clean environment and sanitation. Mary, we are still battling with open defecation. We are still battling with stagnant water, which are breeding sites for mosquitoes, for the vector that causes malaria. We are still battling with unkept and unhygienic environment that has served as drivers for the propagation of malaria. And so those are the kind of hinges that, and even our inability to open up for the malaria vaccine trials here in country. So it goes from having a political will perspective down to having a programmatic perspective that we are unable to include the environmental component of it into the malaria control and then the prevention. In fact, we need to move now from the control to elimination. And so there has been novel technology that has been employed over time in dealing with this. There are what I call environmental genetic engineering, where you crossbreed, you begin to make the vectors to become sterile so that their mating process cannot be enhanced. So I strongly believe that those are the hinges in terms of program aspect, in terms of political will, looking at also a holistic approach in terms of bringing an environmental factor to bear.
So another very important aspect of health is antimicrobial resistance, which is a very present danger. In fact, experts are saying that antimicrobial resistance has the potential, it's not doing it, but has the potential to erase 100 years of advancement in medical breakthroughs. And one case in point is tuberculosis. We now have the multi-drug resistant TB. Now, are we making newer, more effective antimicrobials, or have we discovered substances other than microbials that can handle the same problems? How are we tackling this problem?
So antimicrobial drug resistance is a very major public health problem in developing countries, with Nigeria inclusive. This is because we don't have certain framework and certain laws to be able to check into that. Mary, if you travel to the UK or to the US and you have a prescription of any drugs, they have to look at who is your GP, who is the doctor that prescribed that drug, and then how can we be able to, and then sometimes they can even do a background check to contact the doctor to make sure that it was his prescription that. Doing that eliminates a lot of antimicrobial usage, misuse. But in this part of the world, you can just walk into any pharmacy store. This morning, I was in a pharmacy store where someone just get crashed and said that he needed a drug for 500 naira, that he has been having abdominal pain. The guy selling the drugs just combined certain drugs for him for just 500 naira. And he left to go and take those drugs back home. Now, there are no policies to regulate that. If you go to our motor parks, you see people selling drugs. People that have never gone to school did not even understand the storage mechanisms of those drugs, selling drugs on their head that are being exposed to sunlight and a lot of this. So there are a lot of factors that drives antimicrobial drug resistance that we have. Not only that, most of the quality of the drugs that we even take is being compromised. I know a lot of people that travel to other countries to import drugs, to import antimicrobial drugs, that the standards and the quality is being compromised, is being tampered with. So there are a lot of issues that has to do with that. You also need to look at the environmental factor, because we talk about the effect of the environment even on the antimicrobial resistance. You look at the interface between humans and animals, and also the cross breeding of this etiological agent that cross from animal to humans, and also in terms of changing the genetic makeup of these microorganisms. I agree with you wholly that antimicrobial drug resistance is a major problem in Nigeria. I I agree with you that a lot of organisms are developing multiple drug-resistant, outlook. For example, the TB that you mentioned, a lot of people, not only TB, even HIV and AIDS, there are cases of multiple drug resistance now. People fell in first-line regimen, second-line regimen, and even the third-line regimen. So it's a whole a public health problem, but we need to have a policy approach and a program approach to this. We need to sit down as a nation to come up with a national agenda for how we can be able to tackle most of these public health problems. What is the national policy about antimicrobial drug resistance? What are national policies about the One Health approach in tackling most of these infectious diseases? Those are the national discourse that we must begin to think of discussing in the 21st century, to begin to identify these gaps, just like what you are doing now, and then begin to come up with solutions. And I want to categorically tell you that there are solutions that are hinged on policies, there are solutions that are hinged on political will, and there are solutions that are hinged on health system strengthening. There are also solutions that are hinged on health-seeking behavior and health awareness of what Channels TV is doing that. So there are a multi-array of solutions that we can bring to the table. But first of all, we must have a docile diagnosis. What are our problems and where are the gaps? How can we begin to mitigate these gaps? How can we begin to close these gaps? And how can we begin to move forward? And so when we adopt the India framework of tackling healthcare, antimicrobial drug resistance, they started tackling that by strengthening their primary healthcare system, by providing adequate services. They provide, ambulance services, providing community services in their primary health care, providing a lot of antenatal services,
Dr. Ishaku,
a lot of services from primary health care.
I'll have to come back to you on that after the break. We need to go on a break right now, but we'll continue from where you stopped. Welcome back. This is Health Matters on Channels Television. We're celebrating 75 years of the World Health Organization and talking about public health in Nigeria. My guest is Dr. Akiala Ishaku. If you have questions, call 0808-054-2233. You can also tweet at CTV_Mary A or send me email to moalale@channelstv.com. Dr. Akiala, you were talking about the India approach. I'm interested in hearing what India did. You talked about ambulance service, but how were they able to, bring their public health under control?
And so, before we went on break, I was just talking about ambulance services, which are supposed to be part of the primary health care services that should be provided to primary health care. Mary, you will agree with me that COVID has also exposed the vulnerability of our healthcare system. There are states now, a whole state, you hardly can even get an ambulance with an oxygen component of it. For us to also transfer or transport patients from one point to another. In India, what they did was that they strengthened their primary healthcare system so much that what we have in Nigeria as a secondary care, secondary level of care, healthcare services, it is in India, it is actually their primary healthcare services. In fact, the decrease in mortality, in maternal mortality rate in India was as a result of the strengthening of their primary healthcare system. You go to primary healthcare, you see mothers giving birth and, with close to 0% mortality rate. Vaccines are readily available within a cold chain systems. In case of complications and emergency, there are ambulance services that can be able to transport patients from a primary healthcare setting through a robust referral system and then to a secondary care healthcare facility. And, they have an integrated primary healthcare. What they did was that they midwife both the public and private health centers and designate them as primary healthcare system. Those are the kind of things that there are gaps in Nigeria. We don't truly have them. Mary, what you have as primary healthcare in Nigeria are designated government centers. Is it possible for us to have a paradigm shift in our thinking of strengthening healthcare system to be able to incorporate even public health, private facilities that are of standards of primary healthcare, and begin to see how we can bring them into the network? Can we also begin to see how services that needs to be provided at primary healthcare system, if it is too much for government, for us to also look at how private sector can come in terms of ambulance services, in terms of also referring referral network systems that needs to be in place. So this is what the Indian experience have been over time, and then they were able to curtail a lot of mortality and be able to handle healthcare services at the grassroots level. If you have if you have a notifiable disease in a public facility in Nigeria, sometimes it's very difficult for you to have a network that you can be able to report within a national dashboard that should be captured. That is a kind of, despite it is a private setting. So I think that the way going forward is that we must have a paradigm shift in terms of our thinking. We must see to how we can overhaul our primary healthcare system and see how we can also make investments into the future. So I may ask, what investment in terms of budget line do we have in terms of upgrading our primary healthcare system as a country? What investment do we have in terms of bringing partners to support? What investment do we have in terms of, for the future, in terms of bringing people within the private sector to come in? What investment do we have in our healthcare system to achieve health for all in terms of health insurance and health policies?
Let me quickly take you back.
Insurance in this country.
Let me quickly take you back, Doctor.
And on and begin to
to something you just said. You talked about notifiable diseases and a dashboard. So what I'm seeing is, if that's what you're explaining, you tell me. You have a notifiable disease, you put it on your board, some sort of dashboard, and it kind of lights up everywhere around the country. And everybody knows that this disease has been found at such a location in such a country. Maybe it's Nigeria. This disease has been found, maybe Lassa fever or COVID-19, something like that, has been found in so-so village in so-so state. And everybody gets to know at almost the same time in the country. Is that possible? Is that what you're talking about?
Yes, that is what is supposed to be in the ideal, Mary. We should be able to have a unifying national dashboard. What we have now is SOMAS, and I can tell you that SOMAS is not real time. A lot of Lassa fever cases I've seen and I've handled Lassa fever that are coming from private healthcare system centers that we are being referred to government centers. They are being notified at government centers. Not all private healthcare centers have been captured within a national dashboard to be able to identify a notifiable disease and begin to report real time. And so we must begin to sit down. And this also brings to bear that the next coming government needs to do a lot in terms of setting frameworks.
Okay, before you go into that, let's quickly get Ndubisi on the line. Hello, Ndubisi.
Hello?
Good afternoon. Hello. How are you doing? We can hear you. What's your question?
Oh, my question?
Your question, Ndubisi.
Yes, my question is that, fine, how's everything? My question is that if you go to Pakistan, India, you see them producing drugs locally. We only have pharmaceutical companies. You can't see even one of production companies. Yeah, they are mostly here. Most of these are our states, except that Lagos, Onitsha, and other little states that we can talk. Not more than 2 places or 3 places in Nigeria. But if you go to Pakistan, India, you see, locally, they produce these drugs locally. Where is it in Nigeria? We find it so very hard in producing of drugs.
Okay, thank you so much, Ndubisi. Let me put the question to the doctor. So, doctor, it is a very valid point. How is our drug production capacity here in Nigeria?
Yeah, so I may not be able to be in a position to speak on that, but I think that there are gaps that have been identified. And I think that going forward is that we need to also think of doing a local content development in terms of drug development, in terms of vaccine development. Maybe you agree with me with the advent of COVID, we made noise even on media that Nigeria will start producing vaccines. As I speak with you now, the project is already almost dead because COVID has gone, as people will say. So I agree with him, is that we have in fact, the issue of orthodox medicine and issue of local content development. Time has come for us to look inward to begin to support our own. This is what India has done. Mary, over 70% of the drugs that we take in Nigeria are imported from India. Even the vaccines that we have are produced in India, in Serum Institute in India. You agree with me that the COVID vaccine that was the Oxford AstraZeneca, the production was done in Serum Institute in India. What is so difficult? A nation giant of Africa that we are above 200 million people cannot be able to produce a vaccine. This is uncalled for in a 21st century, a country that is endowed with human resources, a country that is endowed with everything that you can think of. So I think the way forward is for us to look at the local content development acts, maybe, and begin to support our own. Just like the way I said before, Ndubisi called.
Yes, Ndubisi, but at this point, I think this is a very beautiful point for us to call it a day on the program and call it a wrap. Thank you so much for coming on the show. I know there's so much more to say, and we'll have you back talking about these things. It's your field anyway. Thank you so much for coming on the show. And thank you, Ndubisi, and everybody else at home. Have a wonderful day. I am Mary Alale Yusuf.